Jon Trent is one of the very famous and very specialized sarcoma specialists in the world. Very active, a lot of international collaboration, a good friend of SPAEN because you have, well, I can remember many situations that you were present in our meetings and giving presentations, John. So it's really a pleasure to have you here. As I said before, it's a pity that you couldn't join us live as you have planned. Unfortunately, COVID interfered, but please start with your presentation.
Great. I'd like to thank you for the kind introduction. And I'd really like to thank everybody at SPAEN because it's a remarkable group that provides information, service, facilitates high-level patient care to in really a global setting. I know that SPAEN is primarily located in Europe, but the impact that SPAEN has is truly global. And I want to thank you for doing everything you do. And I also want to thank you for the opportunity to discuss some of the latest advances in GIST. Okay, can you see this slide?
Yes.
Is that showing up okay?
Yes, it's fine.
Okay, we'll get started then. Since I'm, so yeah, my name's Jon Trent, and I think with rare diseases, it's important for the physicians, the researchers, the patient advocates, the organizations, for us all to work together and have an open line of communication. When a community oncologist reads something in the textbook, it's already 5 years old. When a community oncologist reads the latest breakthrough in a journal article, it's already 2 years old, 3 years old. So, or older. When it first comes out, that information is already 2 to 3 years old. So having discussions like this with the latest breakthrough is really critical. Meetings like ASCO, you get to see the latest data and for physicians mostly, and meetings like this gets information to patients, the latest information to patients, which is really critical, especially for rare diseases. So I try to maintain open lines of communication. I'm certainly not perfect, but feel free to ask any questions along the way today, or reach out to me at any point in time after the meeting. So we all know GIST, but what I'm going to really focus on is the metastatic setting, when GIST spreads to other organs or comes back in the abdomen or in the GI tract. And these are generally treated with tyrosine kinase inhibitors. The first three that have been around the longest are imatinib, sunitinib, and regorafenib. And I'll be discussing today a feature of imatinib, a characteristic of these tyrosine kinase inhibitors that's called PFS, or progression-free survival. And it's one of the markers that we use to understand how well a medicine, how effective a medicine is at treating a cancer. So a median PFS of 24 months means that after 24 months, half of the patients that started imatinib are still progression-free. So it's that halfway point. The median progression-free survival is the halfway point. So with sunitinib, at 6 months of treatment, half of the patients are still progression-free, meaning their tumors are not growing, but the other half of the patients have some growth. And with regorafenib, it's about 5 months. So this information really set the stage that we need more medicines. 5 months is not acceptable. We need something better for our GIST patients. And that's where the newer agents come into play. And we'll be discussing ripretinib and its median progression-free survival of 6.3 months and avapritinib of 3.7 months, which is also not very effective medicine if it can only control a tumor in half of the patients for under 4 months. However, avapritinib is exceptionally effective at GIST patients whose mutation is in the PDGF receptor. So ripretinib is one of the newer agents, and it was studied in this clinical trial where patients with GIST whose tumors had progressed already and were looking for a new treatment. Patients in this study called Invictus were randomized to ripretinib versus a placebo. Most of us don't like placebo studies, but they get done for various reasons that don't always make sense. But nonetheless, in this study, if the patient's tumor grew on placebo, they could start taking ripretinib. And if the tumor grew on ripretinib, the dose could be doubled to 150 milligrams twice a day. And so this is really the way we look at the PFS graphically, and this is called a Kaplan-Meier curve. And it's a way of looking at the occurrence of events over time. So across the bottom, along the x-axis, you see time, and on the y-axis, you see the number of events or the percentage of patients that have had their tumor growing. And you'll see that point where it crosses 50% is 6.3. So at 6.3 months, half of the patients, 50%, have remained progression-free. Their tumors are still not growing. So that's how we get that number. And of course, not surprising, the placebo did very, very poorly, and the tumors progressed almost immediately. Another marker we look at for efficacy of a medicine is ripretinib. Is response rate. And ripretinib, the confirmed objective response rate was 9%. That means a patient's tumor shrunk by more than 30% in the largest diameter. At the final publication, it was, I think, about 10%. But as we know, patients often don't get a lot of tumor shrinkage, but they do get some tumor shrinkage. And we can see that in stable disease, which includes patients whose tumor shrank some, but not as much as 30%. And so stable disease is another thing we look at. And there was the patients who did benefit from ripretinib could benefit for a very long time, out even past a year at the early point in this study. Okay, I want to spend a little time talking about some side effects. Side effects, I unfortunately often are underappreciated by physicians. There's many studies that show that we don't do a very good job of determining the severity of patient side effects. Also, there's a lot of patients that don't feel like they want to complain and may not even mention certain side effects. So this is an area where we can all really improve. And for instance, at Sylvester, we're doing a lot of patient-reported outcomes or PROs, where a patient can put a symptom into their electronic medical record, and it goes, if it's a severe symptom, it comes straight to me and alerts me, and they don't have to wait for their doctor visit that way. And so we'll discuss some of the side effects from ripretinib on this slide. Interestingly, and this surprised a lot of us, the most common side effect was alopecia, hair loss. That's not something we commonly see with TKIs. We do see it sometimes, maybe a little more with regorafenib, but the alopecia that we saw with ripretinib was almost half of the patients had some noticeable hair loss. And then you'll notice that we have these grade 1 and 2. So grade 1 and 2 are really side effects that don't interfere with your quality of life. For instance, you're still able to do everything that you need to do. You're able to go out to a park, you're able to go to a movie, you're able to go grocery shopping. Grade 3 and 4 side effects are the side effects that are more serious. And these are side effects that really interfere with a patient's quality of life. And you'll notice, thankfully, that grade 3 and 4 side effects are actually very rare, less than 5% or less of patients had a grade 3 or 4 side effect. So of any of these side effects. And so you'll notice that there's a lot of minor side effects with these medicines, but not a lot of severe side effects. If you were to put chemotherapy up here, you'd see a lot more grade 3 and 4 side effects with chemotherapy, for instance. The other one that was a little unusual was the lipase increase. We don't see it a lot. We don't see a lot of, and it's an indicator of inflammation of the pancreas. We don't really see a lot of that that is clinically significant, but it is something that's unique to ripretinib. And then the other things that we see are not that unusual for the other medicines we use in this category, such as the diarrhea, nausea. And I would just like to take a second and mention and share with you our approach at Sylvester with side effects like these. Our approach generally is to try to prevent them, try to prevent the side effects. So if there is a pattern that we see, oftentimes we can intervene with a preventive strategy. So for instance, I'll see a patient who'll come in and say, I take my ripretinib, and 2 hours later, I have diarrhea. And then I have it again, and I have like 4 loose stools a day, and it's interfering with my quality of life. So if you read the box of the antidiarrheals, at least in the US, it says to take it after diarrhea, after a loose stool. And that doesn't make any sense in this situation because you're not going to stop it. It's still going to be happening. So what we do in a situation like this, we would have the patient take their antidiarrheal pill at the same time they took their ripretinib so that we can prevent the diarrhea. And you can do the same with nausea. If you can understand when somebody is getting nausea, you can take the nausea, anti-nausea medicine and prevent it from happening. So we try to prevent side effects rather than treat them once they show up. And then these are some more side effects. I know it's a very crazy long list, and I spend countless times I have to counsel patients that these are all very rare. Look, 1%. But when a patient sees some of these scary side effects like cardiac failure, it's concerning to patients. And I think our medical system does them somewhat of a disservice by listing all of these side effects that are so rare that they're really they're really at very, very low risk for getting any of these side effects. So ripretinib is now approved in many countries around the world as fourth-line therapy for advanced GIST patients, and it does significantly improve outcomes compared to placebo. And yeah, we don't like placebo, and hopefully we'll never subject patients to GIST patients to a placebo study again. Ripretinib is effective with response rate and also improves overall outcomes. The placebo group did largely benefit, but not everybody, and which is something that we're just not very happy with. But the responses are durable. We're learning more about ripretinib every day. And we've also learned that doubling the dose from 150 to 150 twice a day, from once a day to twice a day, is also an effective strategy to control GIST from growing. Now we'll talk a little bit about INTRIGUE. INTRIGUE is a phase 3 study looking at ripretinib versus sunitinib, presented by Michael Heinrich and Sebastian Bauer and many others at this ASCO plenary. And in the INTRIGUE study, patients were randomized 1-to-1 to ripretinib once day, continuous dosing, or sunitinib 50 milligrams a day, 4 weeks on, 2 weeks off, with the option of changing the regimen over time. With the primary endpoint, again, of this progression-free survival. That's one of the primary efficacy markers that we use in these agents. And that just shows a distribution in the randomization. And so, we'll also look at response rate, which again means 50% decrease in tumor size. And the objective response rate in this clinical trial, you can see here on this slide for the exon 11 KIT exon 11 patients, and then all patients. Nobody had complete responses, but there was a 23.9% partial response rate, which means more than 30% shrinkage of the tumor versus 13.4 with sunitinib. And this was statistically significant. Unfortunately, that was not the primary endpoint. The primary endpoint was progression-free survival. And I know this is a busy curve, but the progression-free survival, that 50% point was 8.3 versus 7 in the KIT exon 11 patients, and was 8 and 8.3 in the all comers, but it was not statistically significant. So for patients with GIST, sunitinib really remains the second line therapy overall over ripretinib. Although there may be some subsets that benefit from sunitinib more than ripretinib, such as the KIT exon 9 patients, you can see have more than 2 times median PFS. So let's look at the side effects. And so the more yellow on the or red on a side is a higher percentage of patients with that side effect. So for instance, hypertension occurred in both groups, but was much more common in the sunitinib group, occurring over 25%. So if you just look at this overall, you can see that sunitinib in general has more side effects than ripretinib. So ripretinib is better tolerated. I think most of us knew that. So even though it didn't meet the primary endpoint in second-line therapy versus sunitinib, there is clearly a role for ripretinib in fourth-line therapy. Whether or not we use it earlier in patient care is controversial and can be done on a patient-by-patient basis. So now we'll spend a little time talking about avapritinib, the other new agent. So avapritinib was looked at in this phase 1 study called Navigator. And in this study, patients were treated with escalating doses in a phase 1 style, and really analyzed in 2 groups, fourth line plus and patients with PDGF receptor exon 18 mutation. And this just shows the patient characteristics. And then another table, busy table, albeit, looking at the side effects. And so again, we really focus on grade 3 and grade 4 side effects, which again are fairly rare. With another little bit of a surprise in the study was the anemia. We found that 28% of patients had grade 3 or 4 anemia. And so this was anemia that impacted their quality of life. They may have had to go slower. There may have been things they couldn't do. They may even had to have a blood transfusion or go on a red blood cell stimulator like Procrit or Aranesp, an erythropoietin. And then the fatigue, we all know, occurs with these agents, but a little higher. And then the other surprise, again, rare, was about 4% of patients had grade 3 or 4 cognitive effects. About 40% of patients had some degree of cognitive effect. And again, this is not something that we see, a side effect that we see commonly with the TKIs, somewhat unique to avapritinib. We do see it sometimes with the other TKIs, but not to the frequency and not to the intensity that we see with avapritinib. So it's really a side effect that not only patients have to look out for, but their caregivers. When I'm starting a patient on avapritinib, I talk with their family members to be on the lookout for any cognitive changes. Usually it's losing things like you can't find the keys for the car, or sometimes it's word finding. And so they may not be able to remember a word in a situation. There may be a pause. And then the other thing that we do is we offer baseline neurocognitive testing so that we can get a baseline assessment of their neurocognitive function. And then if there are any changes, we can test again, identify areas of deficiency. And then we have neurocognitive counselors that can help patients address those areas of deficiency that's caused by avapritinib. It's important because the PDGFR patients can be on avapritinib for many years. And so understanding and managing neurocognitive effects is critical. It's rare, but it may be a little more common than we think. It's something to be on the lookout for. And then the other side effects, again, nausea, fatigue, diarrhea, they're all something that most GIST patients are familiar with. Now, I'm really delighted to share with you this slide. And so this is data on avapritinib in the PDGFR mutated patients. And so what you can see here across the x-axis, each bar going down is an individual patient. And you can see that on the y-axis, the negative numbers, -25, is 25% decrease in tumor size. So you can see in this study, all but 2 patients had substantial decrease in their tumors. And the response rate was 86%, meaning 86% of patients had tumors that shrank by 30% or more. So this is an amazing graph that shows how effective avapritinib is for patients that have a PDGFR exon 18 mutation, particularly the D842V. Now here's the same plot, but this is looking at KIT mutated patients. And so these are 3rd, 4th line patients with KIT mutation. The vast majority have KIT mutation. And you'll see that there's also downward deflections in the majority of patients. More than 50% of patients had some tumor shrinkage, but not to the degree of PDGFR. Avapritinib was really designed against exon 18 and exon 17, particularly 18. And the response rate in this type of analysis is this dashed line, and it was 22% of patients, which is really the highest that's ever been seen with the TKI and GIST. So in the patients who do get shrinkage, it can be very robust and very effective for a long time. So the response rates really exceeded that reported in other TKIs. They were durable, and avapritinib is safe. It's not, it does have some caveats in its management to be on the lookout for. So we had talked about an algorithm, and this is somewhat of an algorithm that John Zalkberg published a little while back. And this is the way we roughly think about GIST patients when we see them in clinic. When the GIST has spread to other organs like the liver or the abdominal cavity, critical is mutation analysis. If you're going to treat a patient with TKI, we recommend mutation analysis as the first step. If there's exon 18, especially D842V, the patient goes on avapritinib. If that is not effective, they can go on a clinical trial. Now, if the patient has KIT mutation or other PDGFR, they can go on imatinib. If they get a response, then, or stable disease, we always think about resecting or ablating tumors. And so that's something that pops up at all steps along the way, not just after imatinib. After avapritinib, sunitinib, rego, ripretinib, any of these, when we see a very good response, we always ask the question, is there some way to treat the patient's residual tumors? And so sunitinib is second line, regorafenib is third line, ripretinib is fourth line. And then there's clinical trials. We know about the Cogent study that's open. It's CGT 9486 plus sunitinib to inhibit both exon 13 and 17, the Theseus THE 630, and the IDRX is in the pipeline. So there's lots of clinical trials in the pipeline too. But that may not be the end all of the algorithm. And so there are on the horizon, there are maybe some ways to change the algorithm. Maybe imatinib, sunitinib, regorafenib, ripretinib in that order. Maybe that doesn't make sense for everybody. And I'll share with you some of our thoughts at Sylvester. Well, we know that there are molecular subtypes of GIST. And all of these subtypes are not just important because they drive the biology. These subtypes are important because they determine the therapy. If you have a TRK fusion GIST, you're not going to use imatinib, sunitinib, rego, ripretinib. You're going to put the patient on a TRK inhibitor, such as larotrectinib or other. Same thing with RAF. And then at the bottom, we're starting to learn more about exon 13 and 17 resistance mutations. It's becoming so important that it was, there were two presentations at ASCO this past June. One by Cesar Serrano on ctDNA and understanding differences in 13 and 17. And one by our fellow at Sylvester, Steve Bialik, who showed some important differences in sunitinib and regorafenib in the setting of exon 13. So we're gonna have to pay attention to this, and I'll get to it a little more. I know this is a global meeting, but I just wanted to share with you some terrible news in the US, and that's that only about 30% of patients with metastatic GIST get KIT mutation testing when we looked at this data from the National Cancer Database, and it's really problematic, and can't really understand why somebody would treat a GIST patient with imatinib and not do mutation testing. I understand that the testing rates are a lot higher in Europe, but in the US, it's not good. And so we're really proponents of circulating tumor DNA. It's a non-invasive, rapid way to get the answer to the patient's mutation, but also their resistance mutation. Like I was mentioned, exon 13 and 17, patients who have resistance to imatinib, about a third present with exon 13 mutations and about 60% with exon 17 resistance mutations. Some of them we don't know. That's important because all of these tyrosine kinase inhibitors we're discussing today appear to have some differential activity against these resistance mutations. So on the far left, this column are a list of the tyrosine kinase inhibitors, some of them that we're using today. And then on the left columns are the primary mutations, which imatinib is very, very sensitive, and sunitinib, regorafenib. All of these are very effective against the primary mutations. However, when we get to the resistance mutations, you'll notice there are some differences. Namely, sunitinib is very effective at exon 13 and 14. This is also called the ATP binding pocket. However, sunitinib is not so effective at exon 17 and 18. And you'll notice these other TKIs, most of them tend to be more effective at 17, 18, and not as effective at 13, 14 as sunitinib. Sunitinib is the leader in this area, but it's not effective out here. And that's important because patients might have a 13 resistance mutation. A patient's tumor might have a 17 resistance mutation, or patients may have different tumors with one of each, a 13 and a 17, or the same tumor could have both 13 and 17. And why is this important? Well, Cesar Serrano and myself and Suzanne George and Sebastian Bauer and Mike Heinrich and a bunch of others got together and looked at the data from the Voyager study where circulating tumor DNA was detected. And we found that when a patient had this KIT exon 13 resistance mutation, and remember this study, patients were randomized to Avapritinib or Regorafenib. So in this study, if you looked at the patients with KIT exon 13 resistance mutation in their circulating tumor DNA, they did much better on Regorafenib than they did on Avapritinib. So Avapritinib is not very active at exon 13, as we saw on that table. This is proof. So this is, it's retrospective analysis of a prospective study, but it's clearly some evidence of the clinical evidence of the differential sensitivity of these tyrosine kinase inhibitors when patients are treated with one versus the other, depending on their exon, their resistance mutation. So this is an example I'll give you of a patient that I saw in clinic. And this was a 52-year-old woman with a small intestine, KIT exon 11 mutant GIST with liver metastases. She initially responded well to imatinib for several years. The tumors began growing on imatinib, and this was a while back before when we were just starting to do circulating tumor DNA. So we placed her on, at that point in time, Avapritinib. And so Avapritinib, we placed her on at baseline. And if you look at this red arrow, you can see that this tumor got substantially larger on Avapritinib. And this, but at that point in time, and this was only about 4 weeks. And by that time, we did get the circulating tumor DNA data back and found that it was an exon 13 resistance mutation. And remember, that's the one where sunitinib works the best. And Avapritinib actually doesn't really work very well, as I showed you on that graph. And so what we did was immediately switch her to sunitinib to target KIT exon 11 primary, but also the KIT exon 13 resistance mutation. And you can see on sunitinib, her tumor got smaller, it got darker, there's less blood flow going to the tumor, and she felt a lot better. She improved clinically remarkably. And so this was is just an indication how choosing the right medicine based on not only the original mutation, but the resistance mutation is where really the future of GIST is one of the pathways in the future of GIST therapy, I believe. So really primary and resistance mutations need to be understood to provide optimal therapy for GIST patients. Avapritinib is new, it's active in GIST, the most active at PDGFR, but does have some activity against KIT mutant GIST and is an option in select patients. Ripretinib is safe and effective for GIST patients in 4th line and beyond, and may be an option in earlier lines of therapy, depending on circulating tumor DNA and other factors. The whole Sylvester Sarcoma team and GIST team would like to thank you for the opportunity to discuss our work, and be happy to answer any questions. Thank you very much for the opportunity to be with you on Zoom today. And again, I'm sorely disappointed I couldn't be there in Frankfurt in person. Thank you.
Well, thank you very much. Thank you very much, John. Very interesting presentation. It's nice to see that what you mentioned in the beginning is that at your institution, you pay a lot of attention to side effects of patients. I think that's an important thing, and it's not it's not typical, I think, for all patients in all countries, you know, and it's also understandable that there's a lot of focus on the treatment and the primary treatment of the tumor. And often there is not very much time during consulting with the oncologist to also discuss side effects. Apart from side effects itself, which is important to discuss, it's also interesting. And my first question to you is, do you also pay attention to that? Do you ask patients how they cope with the side effects? Because many, especially with GIST, we have seen that fortunately there was a positive development after 2000 when imatinib came into the picture. And nowadays we have some patients that have been living and with palliative treatment with imatinib for 20 years. And you can imagine that they develop their own coping strategy. And it's interesting to see how they do it, and if it's successful, to see whether it works for other patients as well.
Yeah, I agree with you. I learn a great deal from my patients. I ask them about the common side effects proactively. And then I also ask them if they're having any unexpected side effects, because sometimes they may be having something I don't ask about. And then I do learn a lot from my patients. And, you know, it's, I'm sure people in this room have heard different types of remedies for different types of situations. But one of the, in my opinion, one of the most effective is and we use, there's a soap in the US called Ivory. And the Ivory soap at the foot of the bed stops the cramping in the calves in about half of the patients.
Yeah, yeah.
I don't know whether it's a placebo or not, but clearly some patients benefit from it. I have a patient in Montana who's a rancher and is out on the horse often, and he gets cramps in his hands. And so he puts a slice of Ivory soap in his glove and the cramps go away. Another good one for cramping is pickle juice. I have some patients who drink pickle juice for cramping and swear by it. I have one somewhat spicy patient who likes to drink pickled jalapeno juice. And so, you know, I think there's lots of things we can learn from patients and how they manage their side effects in the real world. I think one of the most challenging, and I'd be interested to hear what the group has to say, but one of the most challenging that I run into is fatigue. Fatigue can be different. Sure. Yeah. Can be challenging. We certainly rule out anemia. We rule out hypothyroidism. We do everything we can to identify treatable causes of fatigue. But fatigue is a real problem with all of these agents. And some patients, particularly the type A, the executives, the CEOs, they don't manage the fatigue very well because they're not used to taking a break at 4 o'clock in the afternoon and putting their head down for 30 minutes. So I find it the most challenging to manage, and I'd be interested to hear what other people's experience has been.
Yeah, well, in this respect, I think it's nice to mention that patients talk a lot about the side effects among themselves, among other patients. For instance, there is a widely used Facebook group of GIST Support International, where we have 6,000 patients worldwide who share their experience and talk a lot with each other. They also they talk about their side effects, and they share also their strategies that they have developed. And we have a patient-driven research project in the Netherlands where we do research on how we can recover the information from the rough discussions in the Facebook group using advanced computational techniques and artificial intelligence. And we just published a paper in Springer Scientific Report a week ago, where we also present results of side effects that we found from these discussions.
That's great. I'm going to have to get that publication.
I'll send you a link. Yes. Okay. Are there other questions?
Yeah. Hello, Jonathan. My name is Jörg Forster. I'm from the GIST group, Switzerland. And we were talking recently just about this liquid biopsy. And we have learned there from our specialists that the results to detect GIST in the liquid biopsy is very low and it is not, in fact, effective. And now you just told us that you had the possibility to identify the exon 13 by means of a liquid biopsy check. Is this a new technique, or is this just for the exon 13?
No, that's a very good question. Actually, we looked at we did circulating tumor DNA analysis on about 150 GIST patients, and some of the patients we didn't find any circulating tumor DNA, so there were no results in a subset of the patients. And then other patients we got great results. And so when we looked at who had circulating tumor DNA detectability, it was patients with progressing tumors, patients with the 3 largest tumors were over 10 centimeters. And so large tumors, progressing tumors, and these patients that had large progressing tumors, the detectability rate was 100% in our study. And we published that also, and I'd be happy to send a link to that. If the tumors were not progressing, for instance, or small, the detectability rate was only 16%. So we limit our circulating tumor DNA testing to those patients that have really large progressive tumors. And we get positive detectable ctDNA the majority of the time, I would say 90% of the time. So it has to do with, I think, some selection. For instance, if you're doing it to detect recurrence, like if patients had surgery and you're doing ctDNA every 3 months to detect recurrence before CT scan, that's not going to happen. We've looked at that in our hands, and there's not enough detectable DNA in GIST patients to detect recurrence before it's showing up on a CT. So that's not ready for prime time. Maybe some of the newer, more sensitive assays, like the exosomes and the RNA, maybe those tests, once they're available, will be more sensitive and will have a higher positivity rate. Does that make sense?
Okay, thanks. Is there another question online? Maybe. If not, thank you so much, John, for your excellent presentation. Very interesting. It was a pleasure to have you here with us virtually. And all the best with your health also.
Yeah. Thank you, everybody. Have a great meeting.
Thanks a lot. Bye.